Okay, so I'm going to move on. So the third talk in tonight's symposium is actually a little bit different from the first two talks. And basically, what I'm going to do is to share with you some real-world cases of patients who have actually undergone BRCA and beyond testing, both in the germline setting as well as in the tumor setting. I'm going to use some examples to basically illustrate some key principles in testing in this area. So just a brief background of the cancer genetics program that we run at our hospital here in Singapore. This is the National University Cancer Institute, Singapore. And we have been running a cancer genetics program since 2001, so it's been quite a long history. What we do in these clinics is that we evaluate the patient's genetic risk based on the personal and family cancer history. We provide genetic counseling, also offer genetic testing in appropriate risk patients, test interpretation, and also formulate screening and preventive recommendations. Just to highlight, this is an adult cancer genetics clinic, so we are not limited to seeing patients with hereditary breast cancer syndrome, but it is the most common group of patients. The second most common group of patients are those with suspected hereditary colorectal cancer, and then the remaining 20% is a mixture of rarer conditions like multiple endocrine neoplasia, von Hippel-Lindau syndrome, hereditary paraganglioma, and so on. So traditionally, the people who come and see us in the clinic are patients who fulfill clinical criteria that you suspect that they may have hereditary cancer syndrome. And in cancer genetics testing is actually quite strict in terms of the principles that we follow. So the patient must be of sufficient risk. And most guidelines would recommend that the patient must have an a priori risk of at least 10% of carrying that genetic mutation before genetic testing should be considered. So these are some descriptive criteria of when to refer a patient for hereditary breast cancer testing. And based on these criteria, probably less than 10 to 15% of all the cancer patients that you would see in your clinic would actually fulfill criteria for testing. But as we have heard from the first two speakers, and as you probably know, in the last 3 to 4 years, there have been what we call therapeutic indications for doing genetic testing, particularly BRCA testing, because of the availability of PARP inhibitor. So on this slide, I summarized the key FDA-approved indication as well as key phase 3 randomized trials that's related to BRCA mutation and PARP inhibitor use. So we have two cancers for which there's an FDA-approved indication, so BRCA mutant ovarian cancer as well as BRCA mutant HER2-negative breast cancer to warrant the use of PARP inhibitor. And then, of course, more recently, we have a phase 3 randomized trial for pancreatic cancer, which is BRCA mutant. So here I want to highlight the first 3 indications, and you can see the commonality here is that BRCA germline mutation will actually warrant these 3 patients with these 3 tumor types to be treated with a PARP inhibitor. But there is an exception here, which is ovarian cancer, and that was covered quite extensively earlier on, where somatic mutation, so if the patient has a tumor mutation, ovarian cancer, it also qualifies the patient to be treated with a PARP inhibitor. But I just want to highlight that the same is not true, at least currently, for breast cancer and pancreatic cancer. Then this trial has also been mentioned. This is the PROfound trial, which is just presented at ESMO this year. And essentially, this is a little bit different because it's metastatic castrate-resistant prostate cancer. But here, the biomarker is in the tumor, and it's a panel of mutations in homologous recombination genes. But there are BRCA listed here. It's very small listed here. But BRCA1, BRCA2, and ATM is in cohort 1, and there are a number of other genes that are involved in homologous recombination. So today, if we want to do a test to identify patients who could benefit from a PARP inhibitor treatment, there are a number of tests. So first, you could do germline testing for BRCA mutations, and that would be relevant for ovarian, breast, and pancreatic cancer. And then you could also test for the tumor for BRCA mutations or a more extended panel of homologous recombination genes that could be relevant to prostate and ovarian cancer. And then there is also the genomic instability score test, which would be relevant to ovarian cancer. So for the tumor BRCA testing or the tumor HRD mutation testing, usually you get that information from a tumor NGS test. Whereas for germline BRCA mutations, we'll get this, could be a single gene test, it could be a multi-gene panel test. So today what I'm going to do is mainly focus on the germline testing for BRCA and beyond, as well as tumor NGS tests, and I'll illustrate with some examples. So firstly, testing for germline mutations in BRCA and beyond. So I've mentioned earlier on that really today, if I see a patient in our cancer genetics clinic, they really fall into two categories. So the first group are patients, the traditional group, so those patients who fulfill conventional criteria for genetic testing. So here you see the main motivation would be screening and prevention for both the patient and the family members. Then there is a second distinct group. So these are patients who fulfill therapeutic indications for testing. So these patients invariably will have advanced metastatic cancer. That's why they fulfill criteria for therapeutic indication. So you can see there's a very clear focus, which is on the patient. They want therapeutic reasons. And the prevention, screening, and all that is actually of secondary interest to the patient. So here I do want to just highlight this point that because in the clinic, if you have a metastatic patient, you're testing for therapeutic reason, you're all engrossed about getting that information for therapeutic, you may forget that the information that is yielded is heritable. But so this is just sensitive information, so it's a reminder that regardless of the indication for testing, genetic counseling remains important. Another important point, which is what we really need to accept, is that because of the widening indication for therapeutic reasons, increasingly more patients become eligible for testing. So, and no country will have sufficient cancer genetics resources to see all these patients. So invariably, many of these patients will have to be tested outside the context of a cancer genetics clinic. So it's actually quite important for oncologists, surgeons who may encounter these patients to be aware of the do's and don'ts of genetic testing. So one important thing when you want to do these tests is choosing the right test. And when we say choose the right test, there are several things to consider. You need to choose the right lab, you need to choose the right methodology, and you need to choose the right genes. So why do we need to choose the right lab? The reason is because most hospitals will not have their own in-house BRCA testing. So generally, if you need to do BRCA testing, most people are using a third-party lab or third-party vendor. But this part is actually not so difficult because all you need to do is to ensure that you choose, if you are the one choosing the lab, just choose a lab that has accreditation that is either clear or CAPS certification or equivalent. Probably more important is to be sure that you choose a lab where the methodology for the BRCA testing is appropriate. So BRCA mutations are distributed across the entire genes and there are no hotspots. Majority of the mutations are single base pair substitutions or small indels, so small deletions, insertions. So therefore, the very basic methodology that must be included must be a full sequencing of the two genes. But in addition, about 10 to 15% of BRCA mutations are large deletions, rearrangements, duplications. So therefore, you must make sure that there is a second methodology, which is a deletion duplication analysis or an MLPA analysis. So now I want to illustrate one case. So this is a patient with young onset breast cancer at 33, no family history, so you suspect that the patient may have hereditary breast cancer. Offer genetic counseling, you provided genetic counseling and recommended genetic testing. And the patient says, I've already done this test called 23andMe, and it says that there's nothing wrong with my breast cancer genes. So maybe just a brief show of hands, how many people know what's 23andMe? Some, okay. So let me just review what is 23andMe. This is an online test. It's direct to consumer. If you look at the methodology of the test, this is a custom-designed SNP array. So it's actually quite an extensive test. It's across the genome, many, many genes, covering more than 600,000 SNPs across the genome, including the BRCA gene. So now I'd like to poll the audience. Given this result, given this understanding, does this patient still need BRCA testing? Yes? Show of hands. Yes? No? Not sure? So the answer is yes, the patient still needs BRCA testing because 23andMe does not comprehensively sequence any gene. So this is not the correct test to detect BRCA pathogenic mutations. So just a reminder that proper BRCA testing must include full sequencing and deletion duplication analysis of the entire gene. Then the next question that you need to answer is, how many genes should I test? Should I just test the BRCA1 and 2 genes, or should I do a multi-gene panel test? And the reason why there is this option is because in recent years, next-generation sequencing is becoming more widely available. So this is a technology that allows several genes to be bundled together. So usually tens to hundreds of genes bundled together. And the advantage of NGS, why we like to use it, is because it is less labor-intensive, so it is cheaper, shorter turnaround time, and importantly, because you are testing multiple genes, it can cover differential diagnosis. And covering differential diagnosis is a good thing because if you're trying to diagnose hereditary breast cancer syndrome, you'll know that while the BRCA genes are probably the most well-known genes, they are not the only genes that can cause hereditary breast cancer syndrome. So this table summarizes some of the key high to moderate penetrance genes that can increase the risk of breast cancer. Some of them also increase the risk of ovarian cancer, and then others may increase the risk of other kinds of cancers. And also, therefore, you can see diagnosing these other conditions will have its own screening and preventive implications. And I've also highlighted in blue genes that also belong to the homologous recombination pathway that were highlighted earlier on. These are germline. So it is possible that in the future, diagnosing these conditions may actually have therapeutic implications, just like what we are seeing now with BRCA mutations. So because of the wider availability of NGS, actually this is already being used in the clinic. So NGS testing is increasingly being used in the clinic to diagnose hereditary conditions. So in our own clinic, we have been fairly routinely using an NGS or multi-gene panel test since 2015. So this is a data set of 460 patients. These are all at-risk individuals, at least 10% chance of carrying a genetic mutation. And we tested them, initially was a single gene test, but after 2015, actually majority of the patients were tested after 2015, and it was with a multi-gene panel. Overall, 30% of patients were found with pathogenic mutations, 43% had no mutations, and 27% had a variant of uncertain significance. So if you were to look at the distribution of the pathogenic mutations, you can see here that about 80% of the pathogenic mutations are in BRCA1 and 2, so they remain key players. But because we did a multi-gene panel test, you can see other mutations, other genes being identified. So there's TP53, PALB2, BRIP1, ATM, CHEK2, and so on. So overall, 20% of identifiable pathogenic mutations are in genes that are beyond BRCA1 and 2. So just give you some specific examples. So this is a patient with ovarian cancer at age 49. Not much family history to speak of. She's referred specifically for PARP inhibitor. And basically, we estimated 10 to 15% chance we might find a BRCA mutation. Did a multi-gene panel test. Patient did not carry a BRCA mutation, but instead was found with a RET51C mutation, which is a low penetrance gene for breast and ovarian cancer. There may be therapeutic implications, even though this is not a BRCA mutation, because there is emerging evidence to show that these patients may be more sensitive to platinums and PARP inhibitors, just like BRCA mutation carriers. This is another patient with young onset breast cancer at 34. There is paternal as well as maternal family history of breast cancer. We estimated about 15-20% chance we might find a BRCA mutation. We did a multi-gene panel test, and again, there's no BRCA mutation, but this patient carries a pathogenic mutation in the CHEK2 gene, which is a moderate penetrance gene. This gene increases risk of breast cancer only, but not ovarian cancer. So screening implications is on breast cancer only, and there's currently no therapeutic implications for this particular gene. Then this is another patient with double primary cancer, initially breast cancer at 41, and then subsequently colon cancer at 53. Sister has ovarian cancer, so this is a breast ovarian cancer family. So we estimated 30 to 40% chance we might find a BRCA mutation. Did a multi-gene panel test. Again, no pathogenic BRCA mutation, but the patient actually has a pathogenic mutation in MSH6, which is a mismatch repair gene that causes Lynch syndrome. So the screening implications for this patient is completely different from BRCA. We're focusing on colorectal and endometrial cancer. And also it has therapeutic implications not for PARP inhibitors, but for immune checkpoint inhibitors. So the advance of multi-gene panel testing does allow us to diagnose more people in the clinic, a wider range of genes, some of which have therapeutic implications. And if you were to look at the testing landscape, there are actually a spot for choice to choose the vendors. There are many vendors out there. It's highly competitive space, so the test cost has also reduced quite significantly, and the test is becoming more accessible. But one challenge when you're doing multi-gene panel tests is that how many genes should you test, and what are those genes? And even if you use NGS testing, you could just choose to test perhaps BRCA1 and 2, or this vendor that we use fairly commonly actually has what they call a 11-gene guidelines-based panel, which are more stringent genes. They also have a wider breast cancer panel, which is a 26-gene panel, so they include some lower-level evidence genes. And then there is a wider 46 common hereditary cancer panel, which would include hereditary cancer genes. And because this is NGS and they've already bundled the genes together, the good thing or the bad thing is that regardless of how big is the panel, the size, the cost is the same to the patient. So it makes it very tempting for you to order a very large panel of genes. The problem here I do want to warn people is that while it's very tempting to order a very large panel, when you're doing hereditary cancer or germline testing, you really need to be cautious about indiscriminately ordering a very large panel. Of course, for tumor NGS testing, this is completely different. So if the vendor wants to put in more genes, it's fine. Maybe the additional information is not actionable, but it's not, at least will not be harmful. But germline is a little bit different because if you test more genes, you might get unwanted information. You could get variants of uncertain significance. So these are things to consider. So for germline testing, you have to be more prudent and not indiscriminately order a very large panel. So firstly, variants of uncertain significance, which is uninformative and not actionable, they would definitely increase if you test many genes. So this is our data set of 254 breast cancer patients tested in our cancer genetics clinic, all underwent germline testing. And basically, we went back and used the data and simulated how will the diagnostic yield and the VUS be impacted if we reduce the number of genes that we tested. So we actually test up to 49 genes, but what happens if I test just 2 genes, 6 genes, 15 genes, or 21 genes? And you can see that the red line is the diagnostic yield, the blue line is the VUS rate. So clearly, as you increase the number of genes that you test, the diagnostic yield will increase, but so will the VUS. But here you see, look at the diagnostic yield. Beyond about 20 genes, it sort of plateau off. It doesn't increase much more. So any additional genes beyond 20 would probably be genes that are not relevant to the patient's condition. But yet the VUS rate is going up, up, up. And up to a certain point, at about 30 to 40 genes, is when the VUS rate exceeds the diagnostic yield. So that's the point that you really want to avoid crossing. So what's the optimal number of genes? We think probably in the range of about 15 to 20 genes, where you are actually maximizing the diagnostic yield, and yet the VUS rate is acceptable at probably less than 20%. Next, I'm going to illustrate one case, use this case to illustrate why it is important not to test an indiscriminately large number of genes. So this is a real example, a patient with breast cancer at 32, so young onset. There's paternal family history of ovarian cancer, maternal family history of colon and breast cancer. So the primary oncologist very appropriately suspected BRCA, but went ahead to order the test and selected a very large panel. This is an 83 gene panel. So this testing showed that the patient has a BRCA1 pathogenic mutation and no other variants, no other VUSs, so that's a good outcome. Then this patient has the 30-year-old sister who came, and we know that she has 50% chance of carrying the same mutation. So now I want to poll the audience again. So which test should you order for the cancer-free sister? So there are a few options here. Okay, so how many people will test the full 83 gene panel? How many people will go for the 11 gene guidelines-based panel? Okay, full BRCA1, single-site mutation analysis. Okay, so the correct answer is single-site mutation analysis because a mutation has already been identified in this patient. So, but this oncologist, basically the patient was seen by the oncologist who went ahead to counsel the patient's cancer-free sister and ordered the same 83 gene panel. So let's take a look at the outcome of this testing. So this is the patient's cancer-free sister's result. So very fortunately for the sister, there is no BRCA1 pathogenic mutation, but because an 83 gene panel test was ordered, there were several other findings here that was not found in the original patient. So first, there is a likely pathogenic mutation in a gene called MARYH. There is a VUS in BRCA2. There is a VUS in PEL-B2, which is also a breast cancer, high penetrance breast cancer gene. So as I mentioned earlier on, VUS is uninformative, but if the patient has that result, it causes uncertainty. So it really can cause anxiety in the patient. And also a likely pathogenic MARYH mutation can marginally increase the risk of colorectal cancer, but it's somewhat controversial what you should do about that. Not sure whether they would benefit from earlier screening, but yet the information is sufficient to impact on the patient's insurability. So the moral of the story is that you don't test unnecessarily large number of genes. So all this information could have been avoided if the correct test was done. So how do you choose the correct test is really context dependent. So if the patient fulfills conventional criteria for genetic testing, i.e. there's an estimated at least 10% chance that we might find a genetic mutation, then they may benefit from a multi-gene panel test, but it may be better to test such a person in a cancer genetics clinic. On the other hand, if the patient only fulfills therapeutic indication but does not fulfill the conventional criteria, then it may be better to just test BRCA1 and 2. Just bear in mind it should be full sequencing and deletion duplication analysis. And if you have the chance to have to manage a cancer-free family member of someone where there is already a pathogenic mutation found, then the correct test to order is single-site mutation analysis. Then after you have ordered the test, now the next step is to interpret the test right. So I'm going to use some examples to illustrate how to manage VUS, incidental unexpected findings, and how to interpret tumor NGS results. So this is a patient with breast cancer at 31. You can see very strong family history, so there is both male and female breast cancer in the family as well as ovarian cancer. So we estimated more than 50% chance we might find a BRCA mutation. Did a multi-gene panel test, and the patient was found with a BRCA2 missense mutation that is classified as a variant of uncertain significance. There are no other deleterious mutations found. So like to poll the audience again, how many people think that the BRCA2 VUS is likely to be pathogenic given the strong personal and family cancer history? Yes? No? Not sure? Okay. How many people feel that this result supports the patient to be treated with a PARP inhibitor? Yes? No? Not sure? Okay. How many people feel that this patient's cancer-free sibling should undergo predictive testing for the BRCA2 VUS to determine the cancer risk? Yes? No? Not sure? The answer is no to all 3 questions because the VUS is uninformative and not actionable. This is different from Shahina's case because she has 3 sisters who all have cancers and who have the same mutation, but even then she cannot be 100% sure it's likely pathogenic. But the way she managed that patient is appropriate, but if you just see a VUS does not mean it's likely pathogenic. So this is another patient, a patient with breast cancer at 49, and there is family history of breast and ovarian cancer. So you can see quite strong suspicion of a BRCA mutation. We estimated 30 to 40% chance we might find a BRCA mutation. Did a multi-gene panel testing, and we were right. The patient does carry a BRCA2 pathogenic mutation. But what was surprising is that there was another pathogenic mutation in this test result, which is a RET mutation. So maybe I'd like to poll the audience again. Do you think that the RET mutation increased the risk of breast cancer? Yes? No? Not sure? Okay. So what does the RET mutation do? Essentially, this is the gene that causes familial medullary thyroid carcinoma or multiple endocrine neoplasia type 2. If someone has this mutation, you expect to see medullary thyroid carcinoma, pheochromocytoma. This is a very serious finding because there are actually very clear screening and preventive recommendations for such patients. But one important thing, if you do the test and you find this, is to recognize that actually the RET mutation, the finding is discordant with the clinical history. So we actually were worried about a lab error. So what we did was that we made the patient take a second blood sample and send it to a completely different lab, just to be sure. And the mutation was actually confirmed. So this is a very rare, unfortunate individual who actually inherited 2 mutations in 2 different genes. Both are fairly rare conditions. She had 2 daughters who went on to be tested, and quite unfortunately, she had passed both the BRCA2 as well as the RET mutation to one of her 2 daughters. The other daughter is fine. So this is an example. If you actually were to do a multi-gene panel test and you find something serious like this, it's actually quite important that you should refer this patient to be managed in a cancer genetics clinic. Next, I'm going to move on to interpreting tumor NGS results. And really in the clinic, if you're practicing oncologist, you will increasingly see these results because we are increasingly ordering tumor NGS testing for patients with refractory cancer. So the question is, how do you interpret that BRCA test result that actually comes out in that tumor NGS report? So this is a patient with refractory breast cancer, underwent tumor NGS testing, and there is, among various genomic alterations, is a BRCA1 nonsense mutation. So this is a pathogenic mutation. So now I want to poll the audience again. Is the BRCA1 mutation germline or somatic? So how many people think it's germline? Somatic? Not sure. Okay. Is the BRCA1 mutation heritable? Yes? No? Not sure? Okay. And can the patient be treated with a PARP inhibitor? Yes? No? Not sure. Okay. So in order to answer these questions, we need to basically understand the fundamental difference between germline and somatic. And actually, there is still some confusion between germline and somatic among some physicians. So I think it's worth spending just one slide to discuss this. So germline information refers to heritable information. It does not change with time, so you just need to test once. Somatic information is non-heritable. It could change with time, so you may require serial sampling. So the usual indications for germline testing is, like, for example, diagnostic to diagnose hereditary cancer syndrome, whereas somatic testing is therapeutic, for example, EGFR mutation testing. Because germline testing yields heritable information, pre-test genetic counseling is crucial, but you don't need that for somatic testing. What about starting materials? For germline testing, it's most commonly blood. For somatic testing, it's most commonly tumor. So most of the time, we will associate blood testing with germline information, tumor testing with somatic information, but this relationship is not exclusive. So for example, tumor originates from normal tissue, so it actually does contain germline DNA. So when you do a tumor test, you could potentially yield what we call incidental germline finding. But the important question is how likely. So if you were to do a tumor NGS test, what is the probability that you might find incidental germline pathogenic mutations? This is a study from MD Anderson, 1,000 patients that underwent tumor NGS testing. It's a large panel of 202 genes. All the patients provided PET, blood, or saliva sample as a germline control, so it is possible to ascertain each tumor mutation is this germline or somatic. This is a focused analysis on 19 cancer predisposition genes, including BRCA. And overall, about 5% of tumor variants that were identified are germline in nature, so this would represent incidental germline findings. But the prevalence, it actually varies between different genes. So for example, tumor TP53 variants are pretty common, but only a very small minority, about 3%, were germline. On the other hand, tumor BRCA variants are not very commonly found, only 3% of the time, but the vast majority, 80%, were germline. So if you come back to this patient, is the BRCA1 mutation germline and heritable? It's actually a high probability that it is germline and heritable, but you actually cannot be sure. So the correct answer is not sure. And this is potentially an incidental heritable finding. Can the patient be treated with a PARP inhibitor in the context of breast cancer is no, because if you look at the US FDA label, the approval language is specifically only for BRCA germline mutation, but you could confirm this on a blood test, and if the patient is confirmed to have a germline mutation on blood taking, then you could actually then treat the patient with a PARP inhibitor. So this is how we interpret if we find a mutation, a BRCA mutation on tumor NGS testing. But what about the opposite scenario? So this is the opposite scenario. A patient with young metachronous breast cancers, age 25 and 30, so again, strong suspicion of carrying a germline mutation. You provided genetic counseling, wanted to do genetic testing, and the patient says, I've already done this test called Tumor Foundation 1. Many genes there, including BRCA, and there's no mutation in the BRCA genes. So now the question is, does this patient still need BRCA germline testing? So again, poll the audience, yes. Does this patient still need germline testing? No? Not sure? Okay. So the question here is how reliable is tumor BRCA testing to completely exclude germline mutations? We did this study actually with ACT Genomics. We just published it this year. 60 patients who have undergone germline testing in our clinic. So we knew exactly what their germline status is. And we retrieved the paraffin-embedded tumor samples and sent it to the lab for tumor NGS testing for BRCA1 and 2. The lab was blinded to the germline results. We did not give them a blood sample or a germline sample as a reference. We just asked them, test the tumor, use the algorithm, and tell us whether this patient harbors a germline pathogenic mutation in BRCA1 and 2. So how did the tumor test perform? So there are 60 patients, 38 had no germline mutations, and the tumor test was perfect, 100% concordant, no false positives at all. But among the 22 patients with pathogenic BRCA mutation, the tumor test could only detect 70% of those mutations. So there is a 30% false negative. And what were the reasons? Half the time it was a technical error, which means that the mutation just simply couldn't be detected in the tumor. And the other half of the time is what we call an interpretation error, which means that the mutation is actually there, but the algorithm that was used in the lab wrongly classified it as non-pathogenic or non-germline. So the bottom line is that tumor BRCA testing is pretty good in identifying the mutations, but it's not exhaustive. So if you don't find a mutation on tumor NGS, but the patient fulfills the regular conventional criteria for testing, then you would still need to do the germline testing. So the key take-home messages for tumor NGS is that before you actually send off that tumor NGS test, you should be mindful that there is a small chance that you might yield incidental germline findings. So it will be good to do a brief pre-test counseling to warn the patient. And if the tumor NGS test yields a BRCA pathogenic mutation, then there is a high probability that this is going to be germline. So the correct course of action is to offer the patient proper genetic counseling as well as confirmatory tests using a direct germline test, which is a blood test. On the other hand, if the tumor NGS test yields no BRCA mutation, then we should note that not all germline BRCA mutations can be detected in the tumor. So if the patient fulfills criteria for testing, then germline testing should still be done. So to conclude, there is now widening indication for BRCA and beyond testing for therapeutic reasons. But if you look at the data, you will notice that some PARP inhibitor data approval is based on germline mutations, others is based on tumor mutations. So this is still an evolving area, but you must be beware of the differences. Just be aware that germline and somatic and tumor is not necessarily the same, and they are not interchangeable. Because of the recent availability of NGS testing, which is now applied both in blood as well as tumor testing, this has facilitated the diagnosis of a broader spectrum of gene mutations that may have therapeutic implications. But while you're doing these tests, you may actually be doing germline testing. So a reminder that germline testing yields heritable information, so we really need to exercise more caution. Thank you.